I want to talk first just a little bit about our mission, which is alleviating patient suffering through medical cannabis. Our model with Aunt Zelda's is that we will work with anybody's doctor, anybody's medicines, anybody's pharmaceuticals, whatever it's going to take to help them to relieve whatever suffering that they're experiencing in their life, whatever that means. And we have found that we can fill in the blanks and then replace with cannabis often, just like you've heard from other speakers today, many of the medications that are working. The other thing is dosing, as you've also heard, it's been a wonderful, informative morning, is that it's very individualized, it's very specialized, and you cannot necessarily predict from one person to the next what the dosing is going to be, which is one of the things that's challenging about looking at creating any kind of good data sets, looking at things beyond just the testing of the plant materials, testing of the content of the tinctures or the elixirs or extracts that you make, but also looking at the way that they take them, the way that the body intakes the medicine in, and then also what other things that they're on, and also their life experience. It has to do a lot with people being willing participants in their care, and that's one of the things that we have found has been a tremendous change in what's successful and what's failure. But what I'd like to do today is I'm going to go over 3 of our case studies. One is from a gentleman with hypertension, one a woman with intractable nerve pain, and one a irritable bowel syndrome. Before doing that, though, I want to show you, here we go. Here I go. I want to show you something we call the shoop. Now, we have, as some of you in this room, many of you in this room are familiar with, there's a lot of problems with dosing. Like, what does that mean? Someone will say, oh, you use a gram a day. Well, a gram of what? A gram of something that's 300 milligrams of THC, something that's 900 milligrams of THC. Is it a gram that's something that's been refined in olive oil, or is it a gram of something that's been done with ethanol extract, etc.? When we're dealing with, because of the model right now, and parents of children, I know we're talking about elderly right now, but that's what first got us going with this thing we call the shoop. They want to be exact to the 0.001 on giving medicine to their children. They are so afraid, some of these parents, of making their kids stoned or getting in trouble with Child Protective Services or a myriad of other, or their doctor finding out, that they want to make sure that, so when, the other thing is with the seizure patients, oftentimes these children can have the difference between 1 or 2 points of THC can be enough of a difference for them having seizing opportunities, seizing behavior. So we had a parent who was doing all this math, and I said, I wish you would build me a calculator. I said, so that I could just plug in whichever numbers I want to, what my goal dosage is, and then tell me how to get there. So he built me this, and the shoop, that's their nickname for their little girl, Sarah, who came to us. And when she first came, she was having in excess of 300 seizures a day. Her seizures are now controlled. They were first controlled successfully with CBD, and then we added in the THCA, and she's doing beautifully. She's down to about 6 or 7, just, you know, basic, small, little interruptions during the day. Now, the way that we read this is, in this particular case, I took 2 strains, and I just randomly put them here, a pineapple strain and an AC/DC. The pineapple strain, as the test results, now, the other thing is everything that we do is tested, lab tested, and it's lab tested by either Steve Hill-Hayland or the workshop. And I know that there's other strains, other labs out there, but that's where we have found the most consistent results over and over again, and something that we can actually track. Now, in this case, now we do also, when we pick strains for patients, we look at the terpenes and the cannabinoids beyond the THC and CBD, but because of time limits today, I'm only going to concentrate on the THC and CBD, and one case where there's THCA. The pineapple strain here, like I said, had 59.1% THC, or 591 milligrams per gram of extract. This is an extract that was made with 190 ethanol, and this is just, and it was randomly, I just picked to illustrate. The CBD content of that was 0.35, or 35 milligrams of CBD per milliliter. Now the ACDC in this case was 2.4 on the THC and 58.9 on the CBD. So they're almost identical strains, just one and the other. Sorry. So anyway, in this, we were able to put in here, okay, we want there to be a dose of 200 milligrams of THC. We want there to be 300 milligrams of CBD. We want it to be 3 doses a day. You punch those in there, you fill them out, and it comes out with this much of the strain 1, in this case 0.318 a day, or 0.32 a day of the pineapple, and 0.507 of the ACDC. So in order to get the cumulative value of the both. Now, so that meant a dose of 0.106, which is about a grain of rice. If people talk about a grain of rice being approximately 0.05, then their dose on the pineapple was just slightly over basically the size of 2 grains of rice, and the ACDC 3. We do, however, have our patients use a jeweler's scale that goes to 0.001. I would rather they did to 0.001 instead of 3, but it does make it more exact, and it does give them more comfort knowing that, because then they have control over their patient. So what we have them do is we have them put down like a little tiny piece of rice paper and put the medicine on there, and then put it under their tongue or in the cheek, whatever, in order to have it absorb into the blood vessels. And instead of sublingually, and instead of having it being ingested down over the tongue. And we find that we have much more consistent results and much more predictable, and we can, in the time from taking it to seeing what the efficacy of it's going to be is much more predictable for the patient, which gives them a lot of reassurance. Now, this first case I'm going to look at here was a gentleman that came to us in 2010. 54. He'd been diagnosed with hypertension. It was exacerbated by his work and the fact that the doctor said that if you don't do something, you're going to have to stop working because the stress is literally killing you. He was 54 years old at the time. By the time that he came to us, they put him on hydrochlorothiazide in a dose of 25 milligrams. By the time he came to us in November of 2011, the medication had become ineffective and he was at a complete loss. This gentleman showed up at an event where I was speaking, and he came up to me afterwards, and I thought he was a narc. I absolutely full blood, because I've never seen anybody be so scared and ask such odd questions. But anyway, so he would have been the example of what we say, cannabis is for everybody, not just, goes for across all boards. The man is like, meet me outside under a tree and I'll wear a hat to get his medicine, Yeah. But since 2011, he has been able to successfully maintain his blood pressure at 120/80, which for somebody who was faced with financial loss and losing their job, that's pretty tremendous. He did change from the hydrochlorothiazide to lisinopril in 10 milligrams, and he's been able to maintain that very, very well. Now, he also, part of what we suggested with him was some dietary changes, and we had him start yoga. And doing the combination of the mind, body, spirit, which is how cannabis seems to work best. Now, I'm not talking voodoo here, but I'm not a medical doctor, so I can be a little bit more voodoo-y up here. But there's most definitely a mind, body, spirit connection between how cannabis works and whether it's how effectively it works in the treatment planning with patients. We find that if they are resistant to the THC, that we are able to help them figure out what their right dose is and get them up to there by first introducing the CBD or introducing just a little bit and then having them go, oh, that's not enough, I'm not doing anything. And then, oh, wow, it did something. Oh, that CBD is so great. And they're actually taking THC. So in the case of this, I included in his own words so you can hear what he had to say. I love how he has here, cotton candy diesel style pot at night before I go to bed. And I apologize that the writing is so small, but the first strain that we had given him back in November 2011 was cotton candy diesel. And cotton candy diesel, this was in the form of an infused olive oil and had been fully decarboxylated, and it had 0.6% THC per milliliter, and it had 0.26 CBD milligrams CBD per milliliter. So we were able to, or milligram. So I was able to give him that one. We set the initial dose at 30 milligrams, one time a day, just at night, before he went to bed. And it was enough for him to have his blood pressure come down, to have his life return to him and still work effectively, and he's been promoted since then. So life is very good for this gentleman. By setting the 30 milligrams of the THC, he was able to get the 13 milligrams of the CBD at that same time. Well, because of the nature of this business, of the industry, the cannabis industry right now, we do not necessarily have access to the same strains over and over again, grown by the same people over and over again, under the same conditions. And that's another reason that testing is so important, so that if we do get it, the name means nothing. Somebody brought us some OG and it turned out to be Blue Dream, for example, or as close to a profile for Blue Dream as I should say that we've seen. Anyway, so when we ran out of the cotton candy diesel, we were left with, okay, now what are we going to do with this gentleman? You know, we know what works for him. So by looking through our other strains and our other results, our test results, we were able to say, okay, let's keep him at that same 30 milligrams of THC and round up the 15 milligrams of the CBD, and let's see how we can create that to give him as close of a terpene and cannabinoid profile using 2 strains as we had with the 1. In this case, we went with the cookies, which had at 0.66% per mil, and then it had 0.01, and then the ACDC, which was, I believe, the same plant as we had used before. No, this was a different strain of ACDC. This one was 0.2 and 0.69. We kept his target dose there, which meant that his the first strain, he had to have 4.482 milligrams, grams, which would be, I believe he was taking, and then of the ACDC 2.10, I believe he was taking 4 droppers of oil in total, and it was enough to keep him still going beautifully. The next time we did it, we had him on the cookies and the ACDC for a while, and then lo and behold, didn't have any more for him, and we switched him to a strain Pepe Le Pew and Swiss Gold. Yeah, the names are just something else, aren't they? I think that in the aging population, they kind of enjoy the name. They're a little bit tired of the pharmaceuticals that they can't spell or pronounce, and it's kind of fun. Like, I want to take some Cinderella 99, that kind of thing. So I want to be Cinderella. So anyway, we were able to produce the same results with the Pepe Le Pew and the Swiss Gold by putting him on, and as you can see, because of this calculator, we were able to put in precisely what the lab results were from testing and give them an accurate to the milligram dosing as a result, and optimize results. On this time, he was at 3.133. and at 2.129 on the Swiss Gold, which was what we considered the high CBD strain on this. Now, the next person I'm showing you is a woman that came to us. I'm just going to skip forward for a second and go back. This is why I wrote a summary. This is her in her own words. She came to us with her primary complaint being intractable nerve pain. And it had been over 30 years since she had had a good night's sleep. This is a woman that was woken throughout the night with cramping and horrible intractable nerve pain in her feet and her legs and her hands. Then she went through chemotherapy a second time, or she went through chemotherapy from a recurring non-small cell lung cancer that she had experienced in 2007 that recurred in 2010. And at that point, she then had the nerve pain during the day as well, and not just at night. So she became a constant sufferer. And I believe in 2011, she developed lockjaw. And she's what we call a super sensitive, meaning that she is, a slight variation in the dosing can make all the difference in the world to her, versus somebody that you can give 50 or 100 and there's no difference. There's somebody you give 50 and then 51 and it's like too much. We kind of look at our method of our approach to dosing similar to what Linus Pauling did with the vitamin C, in the sense that everybody does have their own level, and it's up to us to help them to find it. And then so that we don't come in saying this is the expectation of what you're going to use. Anyway, this woman had had TB she'd had PCOS, she'd had a total hysterectomy, and she'd been on Flexeril, Valium, various opiates, and nothing had worked for her. She was unsuccessful with all of them. So when she came to us, she was pretty suicidal at that point, because she did not think that there was any hope and there was any chance of her getting out of this 30-year cycle of no sleeping. And she had further developed these other problems that were exacerbating her unhappiness and her displeasure with life in general. So when she came to us, first thing I did, well, let me just back up for 1 second. When I say that we gave her 30 milligrams of THC and 15 milligrams of CBD, let me back up to that and say we started her out at 1 drop. One tiny drop of the infused oil, which is this is the infused, not the extractions that I'm talking about in these slides. Rarely do you need to use an extraction when you're dealing with serious disease. I mean less serious than like maybe advanced cancers, certain other things that, seizures that require large dosing. It becomes far too complex and too much responsibility to try to dose correctly every time when you're using the extract. So we go ahead and we infuse it into the oil so that we can give them where each thing is 1 milliliter, 1 milliliter is equal to 1 dropper full, so that we're able to dose them. When they get above 5 5 droppers, then we move them to the extract. Most people don't move anywhere near that. We started her out on Game Changer and Canatonic. Now the Game Changer was at 0.9%. It was pretty rugged high THC strain. And then the Canatonic on this one was a 3-to-1 at 0.61 CBD to 0.21 THC. In her case, I wanted her to take this over 3 times a day. And so so that she would have continuous treatment, so that 30 and 15 milligrams were divided throughout the day. And on the Game Changer, she would take 0.92 grams 3 times a day, and then on the Canatonic, the 0.818. So that she was able to have a continuum on a 24-hour a day. Take one right before you go to bed, take one right when you wake up, take one about 8 hours later. We had her on a 24-hour cycle at every 6 to 8 hours, depending on symptoms, but it was about 8 hours. She was doing very well, same problem again, ran out of the medicine, had to get some more, and we went to Purple Kush and AC/DC. Now, in this one, she was singing the praises in the world, and life was worth living, and everything was wonderful. But she still was having breakthrough, and she's like, well, I know it's not going to cure me, I know it's all that, but it's helping. And I was like, well, helping isn't good enough. We can do more than help you. If we don't have it yet, let's keep working. We are not done. We have more to do. So with that, we switched this nice woman back to the Swiss Gold, which was a beautiful high CBD strain at 0.69, it's 600 and, well, no, it was 0.69 percent CBD in the infused and 0.07. So it was a really relatively low amount of the, in this case, with the target dose of the 15 milligrams of CBD, she would still be getting 1.5 milligrams of THC. But we went ahead and we introduced a strain that an infusion that we made from THCA, and we thought, well, this isn't working, so let's try something else. Let's see, because it's all inflammation, it's all dealing with nerve pain, and we know from our seizure kids, and we know from just in general from the work that William Courtney's done and others have done, that THCA, we don't know how it works exactly, but we know it does, and so we're going to utilize it. So we switched her to, kept her at the 15 milligrams of CBD, but we were able to, in this case, take her down to 15 milligrams per day of the THCA to have, and with that, in this particular strain, let me show you first real quickly, it shows the 3.7% THCA and 0.93 of the THC. So even with her getting the 15 milligrams of the THCA, there was residual amount of about 3.8 of the THC. So if you add those together with what came from the Swiss Gold, she had a total of 5.3 milligrams of THC in a 24-hour period. And she was able to have the Swiss Gold to take the CBD throughout the day and just take the THC at bedtime, and it was enough to take it over the edge and remove her symptoms. And now she's full of life and joy and happy and doing all kinds of volunteer work, and she has a website and a blog on breathing and the importance of breathing correctly for health. She's a wonderful woman, and I'm so happy we were able to find her some success and help her with this beautiful medication, cannabis. Now, our third patient that I'd like to cover is a woman who's 54 years old. Now, these first two patients, let me say, neither of those two people had prior cannabis use at all. So it was starting with a tiny, tiny little drop. We start them like, if they're going to use the extract, we say like the size of smaller than a poppy seed to take the first time. And if it's the infused oil, we'll say 1 drop sublingual. And at first I was thinking, okay, this is a bit ridiculous to do this. But people would be going, oh my God, I couldn't get off the chair. And they'd had 1 drop. Or somebody would say, we actually have desensitized patients by having them put it on the inside of their wrist to have them start to have it soak in more slowly in order to be able to handle the effects from the cannabis if they're that sensitive. And some people, especially in the geriatric community, past age about 60, the differences in cannabis requirements and somehow metabolization into the body it changes. Even for lifelong users, it changes. For the most part, what we're finding. This woman, on the other hand, that came to us is a dynamic, active executive in the banking industry, and she was a lifelong cannabis user recreationally. We still treated her precisely the same way, starting from ground zero, saying we start with a drop, let's see how you do. Smoking is not the same thing as taking it internally. In her case, we gave her 3 strains to begin with of infused oil. One was the pineapple. In this case, the pineapple had the 0.44% and that had no detectable CBD. And we gave her cookies, which was some people say Girl Scout cookies. We say, bananas, whatever. But in this case, it was called cookies, and it was 0.66 and the 0.01. So both of those were high THC strains, and then we added back in the cannatonic. But the thing about the pineapple and the cookies is we had their profile, so that we had the CBG, we had the THCA, we had THCV, we had a number of other cannabinoids and terpenes, and such as myrcene, linalool, alpha-pinene, etc., just in there, and wanted to make sure that the strains were different enough that we can get an idea of what was ringing her bell most efficiently. In her case, it turned out to be the cookies. The pineapple was the wrong strain. The pineapple actually contained, alpha-pinene, and was not giving her the relief that she needed at all. She, in fact, it was making her anxious. She had, besides the irritable bowel, she had Lyme disease she'd been diagnosed with, and she was a cancer survivor from years prior. So once we had established what the best profile of strains were going to be from her, because she was all over the board on her inhalation of combustibles, so we couldn't say, oh, she prefers this or prefers that, and what you prefer recreationally may or may not be what's going to be best for the symptoms you're dealing with or with your diagnosis. But we were able to, with the cookies and the Cannatonic, in this case, create for her a treatment plan where she was doing 2 doses per day at, on the cookies, 2.023 grams, and on the Cannatonic, 0.787, and of each of one of those 2 doses to successfully manage her symptoms. We then we didn't have any more Cannatonic, we then had the ACDC, and we had to start over, figuring out again, now what's the dosing going to be, and is it going to stay the same? In this case, she went to, we changed the dose up to 15 milligrams of CBD. We left it at the 30 on the THC, and she did very, very well at that dose, much better actually. And then when we ran out of that, we went to Pepe Le Pew and the ACDC, we were able to maintain a dose where it, from the patient standpoint, it's quite seamless on the differences in their medicine. They don't necessarily feel that we have changed their medicine. So we do or don't change the names on them. Well, I'm getting the done thing, so I just want to go through, I'll go to the conclusions here. And this is what's important. I mean, I didn't go into the fact that we have a whole nurses program and we do the whole patient intake and we work with patients at a very, very high level of complexity, looking at the ID1 gene and deciding whether it's going to use CBD for cancers or whether you're going to use the THC as the major player, looking at things like do their pharmaceuticals go through the P450, the cytochrome P450, when deciding whether how we give their medications in order to maximize the benefit of the THC and CBD without risking the benefits of the pharmaceuticals. Because especially in things like Keppra, and with a lot of seizure, if you have to give it the couple-hour difference, we find that by just varying at 2 hours the difference from your pharmaceuticals, we can alleviate those symptoms. The other thing is, the reason that we separate out the CBD and the THC is because CBD is in fact a CB1 antagonist. We find that patients have the maximum benefit of what the medicine has to offer when they take their THC and then their CBD, or vice versa, with a couple hours, an hour to 2 hours in between. And we've been able to keep the doses much lower on the THC by separating out the CBD and get far greater results. And the only thing I'd like to leave you with is that it is possible to dose correctly and consistently. Individualized treatment plans are necessary. Must do patient intake, must understand the whole health situation of a patient when you're working at them. You cannot just treat them for the symptom that they come in with or their main screaming cry, because that is in fact just a symptom. Usually it's pain or depression or anxiety or PTSD or ADHD. These are symptoms of what's going on in the body that we need to address. Separating the THC and CB doses greatly influences the difference in results. And then we must obey best practices in the extraction and the oil making, because there's a lot of things being out there being made with butane and isopropyl alcohol and hexane and the other anes, and I can tell you they are not medicine. They are, they are not medicine. If it is not made with something that you can healthily put in your body on its own, it is not medicine. And just because it has the word pharmaceutical grade, what does that mean? You can clean the floors and counters in the pharmacy with it? Not my child's belly, because we've had to clean up a lot of those messes from other people. Anyway, and then the full patient adherence is key to success. The patient is engaged in being successful and having cannabis be part of their regimen as their family members do. They have to want it just as much, which is by part of our patient intake, is that we ask people to give us their level on a Likert scale of commitment between 0 and 10 to their success, and that doesn't get shared with anybody. So we know what you put in will get out. And then the testing in the supply chain must improve for cannabis to succeed as a medicine. It's a crime that we have to do this with patients. We have to go, I mean, I can't imagine me having to go for a thyroid medicine and every month having to go and play Russian roulette that it will either be available, there'll be something comparable, or somebody will have the sense to compound something to create what'll work for me. Because to not be able to consistently have medicines that are available over and over and over again in controlled growing situations, with regulated of what is medicine and what is recreational, what is medicine and what is moonshine, that I think that we will continue to be up against barriers out in the general population, the pharmaceutical industry certainly, the insurance industry, and I can tell you as somebody on this end of it, it's my constant pain that I would appreciate to have taken away. So thank you very much.